Hey, I'm Dr. Burkhard Sievers, professor of medicine and specialized in cardiology, vascular medicine, gender medicine, and also I'm a board member of the German Society of Gender-Specific Medicine. Gender medicine is gaining more and more attention in Europe and across countries. However, it all started in the US, and the US was the first country where gender medicine was an issue, and also where most of the research is coming from. So they have the most experience also in setting up the gender medicine programs, especially the woman heart programs. And this experience also has Dr. Ampara Villablanca. And I'm interviewing her today. Hello, Amparo. Can you please introduce yourself and tell us a little bit about you?
Yes, thank you so much for the invitation to participate in this, and thank you for taking the initiative to bring attention to this topic. My name is Ampara Villablanca. I am professor of cardiovascular medicine at the University of California, Davis. I hold an endowed chair in women's cardiovascular medicine, and I also chair a group for inclusive leadership for women for the University of California healthcare system. And it's really my pleasure to participate in this with you.
Yeah, thank you so much. It's a pleasure for me to have you, and I'm honored that you participate in the interview because you have so much experience. And when I did my research, right, you were the first, one of the first in the nations to implement a women's heart program. Is that true?
Yes, that's true. It's interesting. I didn't know it when I started the program in 1994. And the way I found out was many years later when I received an award for that. So sometimes we're pioneers, but we don't really know it. Yes,
yeah,
thank
so
you.
I'm glad to talk to the pioneer of gender medicine. So I'm very honored. So
My pleasure.
where was your strong interest for women's heart disease coming from?
Well, you know, it really sort of stemmed from my own understanding of the lack of recognition and awareness about gender differences in cardiovascular disease, the under-recognition of heart disease as the leading killer of women, the underdiagnosis and the under-treatment. And other than that, of course, things were not fine. And so it just really became a driving imperative for me to try to do something as a physician and cardiologist to bring down deaths, which when I started our program were about 500,000 women were dying of heart disease every year in the US. And so it was really an imperative to address clinical care, but also to engage our community in this effort to do research that was gender specific and to educate at all levels for all learners, from our medical students all the way up to our practicing health professionals.
Yeah, you know, it's a very important issue, and we have really different symptoms and also treatments for women compared to men. So myself traveling pretty frequently back and forth between Germany and the US, I noticed that every really good hospital or clinic in the US actually has a women's heart program. So we do not have that in Europe or in Germany yet. So we're just at the very beginning with all these. So why is it so important to offer a women's heart program?
Oh, I think there are a number of reasons. First, we have to understand that women are not small men and that, you know, there's a different biology. And by that, I mean that sex, S-E-X-X, matters. And that really translates into differences in the presentation and the symptoms and the outcomes and the treatment and the side effects. It's a field that's very, very rich in gender differences. And it's an understanding, bringing an understanding of that to our clinical practice and care that really allows us to deliver patient-centered care, which is the model of health that we use at UC Davis and in many other institutions in the US, where the patient is at the center of everything that we do. And that includes attending to gender-specific aspects of the disease.
So yeah, that is so true. So, and you know, what actually does it need to start a women's health program? So that is something that interests a lot of people, also in the hospitals in Europe and in Germany. So when they start, actually, they have the awareness, they read about it, they studied, they did research, and now they want to actually set up a women's heart program. What is the most important subjects or issues you have to care about?
Yeah, and I think this can take many different forms depending on the institution. When we started our program almost 30 years ago now, it was one of the first multidisciplinary and interdisciplinary programs in our own health system. Of course, now this is the model of care that we have, and integration and even transdisciplinary with nursing sciences, etc., you know, is now much more common here in the US and perhaps also in Europe. But I think that you really need to have a clinical focus, and that is the patient-centered, women-centered care around cardiovascular disease, and then really focus on some of the conditions that have a higher prevalence in women or are unique to women. So for example, SCAD, spontaneous coronary artery dissection, where the arteries tear and can cause a heart attack that is not due to blockage in the heart arteries. That's a condition that's female predominant. All of the pregnancy associated conditions, which we call the maternal placental syndromes, and these are conditions like high blood pressure in pregnancy, diabetes in pregnancy, preeclampsia, which is a hypertensive emergency type condition in pregnancy. These are all conditions that we thought were only pregnancy related, but now we understand confer higher, significantly higher cardiovascular risk longer term for the mother, but also for the infants that develop in that intrauterine environment. We have conditions like angina, chest discomfort, heart attack, due to non-obstructed coronary arteries. So we don't have to have blockage in the heart arteries to have a heart attack. And we know now from the work of my colleagues here in the US and worldwide that this is a prevalent condition. We call it ANOCA or MNOCA, NOCA for the non-obstructive coronary artery. These are conditions that are present in males and women and females, but much more prevalent in females. We have the dysautonomias, which are the abnormalities of the nervous system and how it interacts with the heart, and tachycardic symptoms like POTS, which is postural orthostatic tachycardia syndrome, which interestingly is something that we're seeing more of now with long COVID. So this is now an intersection of the pandemic with existing cardiovascular disease predominance in female, and we call this the syndemic now, this kind of synergism of these conditions. And I could go on in naming additional gender-specific or gender-predominant conditions, cardiovascular conditions in women. And so for these and others, we really need to understand the sex and gender biology, how they present differently, why they're more common in women, and apply appropriate guidelines-directed therapy to optimize the care of our patients.
And how does it work practically if patients come to you? So you obviously you have an outpatient clinic, but you also have like inpatient facilities. And when the patient have to be in the hospital and stay in the hospital, is there a separate ward, or are they mixed up with other cardiology patients or with other diseases?
Right. So our outpatient clinic is a focused clinic on women's cardiovascular medicine that is embedded in our general cardiology clinic and program.
Yeah, it
Uh,
often
and
is. Right.
and therefore, yeah, I can take advantage of the programs that we have there, including cardiac rehabilitation, heart failure, our device for patients with pacemakers, for example, our structural heart clinic for patients with valvular disease, so we can interface with our specific focus programs in the outpatient setting. In the inpatient setting, we don't have a specific ward or area where patients are admitted to our cardiology inpatient service, and we can provide consultation as needed. And we also have a consultation service that's not gender specific, but is staffed by my colleagues in cardiovascular medicine. In other institutions, there may be different models, but at Davis for inpatient care, we really just have our ICU service, our consultation service, and then all of those subspecialties of cardiovascular medicine that can be brought to bear in the care of our women heart patients.
And how many colleagues are working in this gender-specific setting with you together?
Well, I would say that we should all be working in this
Yeah,
gender.
that's so true. Yeah, but
Right, right. So I would like to say that our entire group, it should be part of this effort, because really it shouldn't be the responsibility of just a women's heart physician or a women's heart program. That this is obviously necessary because of the focus and the fact that we still have very high deaths and all of the different gender specific aspects of disease. But, you know, it is not just a women's program and problem. And so I think that we all need to be educated and versed and feel comfortable. And the American Heart Association has shown that physicians have a lot of discomfort in this area. And I think it comes from lack of knowledge and awareness. And programs like yours, like what you're doing, hopefully contribute to increasing awareness and making health professionals more comfortable with management of cardiovascular issues in women, because it's the leading killer.
That's so true. And speaking of the awareness, that is very important for everybody, but obviously most important also for the medical staff, for the colleagues, for the doctors, for the nurses. So they have to get trained and educated. But in Europe, I don't know about the US, but you will know, there are not really educational programs for women heart disease or gender-specific diseases implemented in the medical school or even in the education when they in the fellowship programs. So is that any different in the US?
Yes, and I think that this is a really important point, because we need to really kind of move towards integration of gender-specific medicine into everything that we do, right from basic science to education to care to how we engage with our patients in the community. And so we are moving towards that. I can't say that, you know, I think that it's perfect, but we've just redone our medical school curriculum at Davis, and this effort is going on nationwide to better address not just gender-specific aspects of care, but also race, ethnicity, health disparities, social determinants of health, and many other topics that are cross-sectional and really need to be part of our conversation and the way that we educate the new generation of physicians and health professionals. We also have very specific focus programs for community education. For example, we have a yearly community education and awareness forum where we bring community leaders in our regional area to us, and they spend a better part of a day in an interactive program that's educational, where they learn CPR, they learn symptoms, how they're different in women. They learn about the risk factors and the different cut points and how they may be different in women and so forth. And then they become ambassadors of heart care and educate the members and the communities groups that they serve. So this is a way for us to try to ripple out the information and the education. And another example that I'll provide is our Women's Health Conference, which I started almost 30 years ago. And that conference is a 3-day conference, and the first 2 days are all devoted to cardiovascular disease, again, because it's the leading killer, and by placing additional emphasis on it in a women's health conference, we convey that message. But it allows us to cover head to toe gender medicine. And this is another activity that we have been doing. The topics and the focus area obviously changes from year to year, but it's our way to help to educate health professionals, including dietitians, pharmacists, clinicians, nurses, etc. All of us are involved in women's care, and it's important that we all become educated and more comfortable.
I think the education is the most important part, everybody should know about it and take part. That is very, very important. But a little bit, you talked about the cardiovascular risk factors. We all know, I mean, hypertension, diabetes, high lipids, obesity, smoking, but there are these additional female risk factors for cardiovascular disease. Can you talk a little bit about those?
Sure, yes. And they fall in the category of what the American Heart Association calls risk-enhancing factors. And there are many, many of them. The gender-specific ones are menopause before the age of 40. That's recognized now as a risk-enhancing factor. Also, the gestational disorders that I mentioned before, gestational hypertension, diabetes, eclampsia, and preeclampsia. A family history of premature cardiovascular disease, which has a gender cut point that's different for males and females. So, for example, if you have a first-degree relative that's a male, that would be a parent or a sibling that has had heart disease at age less than 55, that becomes a risk factor for you. But if that relative is a female, the age cut point is age less than 65. And so those would be for 3 examples. But isn't
it that most of the risk factor models and guidelines for cardiovascular disease do not account currently for those female or enhancing risk factors? So isn't there enough data, or are they coming in the guidelines? Because there is research going on, right?
Yes, yeah, and they actually are in guidelines. There have just been some, there's the effectiveness guidelines for heart disease prevention in women that were issued by the American Heart Association several years ago now. And there have been updates to those guidelines in the US that address many different aspects, including testing, for example, the risk factors, and other topics. And so I think this is starting to become embedded into guidelines so that we recognize that, like I said earlier, women are not small men, and that we need to understand the gender-specific aspects of cardiovascular disease to properly take care of our women patients.
What I meant was, if you look at the risk factor calculating models, so there's only this diabetes and hypertension, all these traditional risk factors, but they do not have any of those enhancing risk factors in yet, and they do not account for this. So I think there is some work to do to also include those to the risk factor score models.
Yes, yes, I know exactly what you're saying. That our ASCVD risk score calculator doesn't include the risk enhancing factors. However, there's now, there's mention that we should consider the risk enhancing factors, and they may very well help us to recategorize our patients, men and women, into a higher risk category if they're present. But I think we're going to see more and more of this because, of course, the initial risk scores were validated for the traditional risk factors, but we understand that there are many others that we also need to take into consideration.
Yeah. So what I'm curious, so what are the most surprising or exciting recent research findings for you regarding gender medicine?
I think I'm going to have to go to my current area of research, which is the intersection of heart and brain health. So we have a new award to establish a center for women's cardiovascular and brain health. And this has stemmed from the increasing recognition that the risk factors for cardiovascular disease, such as elevated cholesterol, high blood pressure, diabetes, and obesity, are also risk factors for dementia. And of course, in the US, dementia is the fourth leading cause of death for women, higher than for men.
Very important topic.
Right. And so we are starting to adopt the model that we need to protect our brains the way that we protect our heart. And so we and others are really starting to move to this new area, this interface area of the intersection of cardiovascular disease and dementia and brain health, and trying to understand how the risk factors play a role in the brain, especially in the microvasculature, the small little blood vessels that are the ones that appear to be the most important in dementia risk. So this is an area that for me is very exciting, both personally.
It is, yeah. And there are more and more people with dementia, so it's growing, yes.
Exactly, and the toll in women is well, the toll for everybody is very significant. But women provide most of the care, and there are interesting gender differences in dementia as well. And like I mentioned, it's a fourth leading cause of death in the U.S. for women. So this is becoming very, very important health issue.
Yeah. So it's very interesting. So there's a lot to come, a lot to research. So Amparo, thank you so much for giving us an insight in what you do, what your research is, and also in the Women's Heart program. And you as a pioneer, I'm so happy that I could meet with you online here. It was a pleasure meeting you.
And my absolute pleasure as well. And thank you so much for doing this work. And I do hope that it's of help to your audience, so that together we can all work to reduce deaths. Thank you.
Thank you so much. Let's keep in touch.
Absolutely. Thank you.